Okay, welcome back everybody to the lobby of our event. Everybody should be back from the speed dates. I hope some of you actually attended there. I did some myself also, and it was very much fun to do. So it's a quick talk with somebody for 5 minutes. We'll have the opportunity to do this again in the next break and also at the end of the event. So if you still want to do it, it's still possible to meet some new people. What we will go to now is the next presentation of our schedule, and we will not be doing that presentation in one of these separate rooms, but this presentation will be here in the lobby by Jiapan Guo, and she will talk about AI in radiotherapy, deep image feature networks for prognostic outcome prediction. Jiapan, the floor is yours.
Screen. Oh, could you help me to? I cannot read this. Is it a
Nodig volledig scherm.
Oh yeah, thanks. Okay, that's it. Okay, yeah. Thank you, Peter, for the introduction. So good afternoon, everyone. Yeah, welcome to this session of the symposium. So my name is Jiapan. I'm a postdoc researcher working for the DAME project, and I'm also from the Department of Radiation Oncology from the UMCG. So today I will be talking about artificial intelligence in radiotherapy. But this is a so broad topic, so I will just make it more specific on the deep learning, deep image feature networks for the prognostic outcome prediction. So this is also the project I've been working for the DAME project. Okay. So yeah, as we all know, artificial intelligence is reshaping the data science related research and applications. So the availability of like high dimensionality data acquired in a hospital or from the medical institutes and coupled with high performance computing resources, and as well as also the innovative deep learning architectures has led an explosion of AI use in medicine. So this of course includes also the radiotherapy. So here is actually, you could actually see AI is involved in many different steps in the radiotherapy workflow. So from, for instance, the segmentation image registration, where we need to actually perform like contouring of the tumors and also the healthy organs, and to also image registration, where we need to actually register like a scan, one scan from the other within the same modality, or can be from one modality to the other. And also AI is also involved in image synthesis, where we actually use it to, for instance, to reduce the metal artifacts that very often appear for the head and neck cancer patient, and these very often generate the image quality. And also, for instance, we also use it to generate like synthetic CTs from the MR scans, and eventually we could just use MR only radiotherapy. And it is also applied for the treatment planning. So for instance, we need to calculate the dose and the dose distribution, and also for the planning of the treatment. And at the last, it's also involved in the outcome prediction. So this is also where my talk will be about. There are two types of outcome predictions. The first one focuses more on the tumor part, so it's more tumor-related outcomes. So where we focus on, we look into the tumor and try to find the underlying features that are there in the scan and try to predict the prognosis of the patient after treatment. And the other side is the toxicity prediction, where we are not looking at the tumor itself, but the organs. So for instance, in this image, you could see there are these structures. They are the parotid glands. So this is one of the glands that produce saliva, and this is related to a complication that is dry mouth. So at this moment in department, we have already a normal tissue complication probability models, and based on the clinical parameters, and they are ready for use for the patient selection for the proton therapy. So this is a bit overview of how AI is applied in the whole radiotherapy workflow, and I will just move on to the topic of today. So I would like to start with a simple case. So you could see there's a patient who was 56 years old, female, and when she entered the department, she was diagnosed with oropharyngeal cancer. So here you could see there's a tumor that indicated by these green regions. So this is a primary tumor, and this is also the region where the radiation will focus on. And at the same time, she was also had the lymph nodes. So there were also tumor cells that invaded to the lymph nodes regions. So she's actually was in a locally advanced stage, and luckily not yet with metastasis. And after discussion with the tumor board, she was actually given the concurrent chemoradiation. So this is a treatment that combines both the chemotherapy and also the radiation therapy. So after the treatment, she was in a follow-up procedure, but at 4 months later after the treatment, she was diagnosed with recurrence in the primary tumor region. So there was tumors again after the treatment, and at the primary tumor regions, so the green region, and then at 7 months later, and then the recurrence also in these lymph nodes region, and unfortunately also the tumor cells spread to the distant organs. So chemoradiation is one of the primary treatments for the head and neck cancer, but also for the lung cancer. So around 30 to 50% of the patients in locally advanced stage, they still experience treatment failures. And in this way, prognostic outcome is very important for optimization of the treatment plans, and also eventually leads to personalized treatment planning. So in a more specific case, we could see we can use models to actually identify patients who has maybe low risk for the complications, but then high risk for the tumor recurrences, and this patient could be offered with a more intense treatment schedule, for instance. So anyway, so then I mentioned also those treatment failures, and these actually includes the following ones. So the local recurrence, I actually already mentioned a bit. So that means there's a recurrence after the treatment around or within the primary tumor regions, and then the regional recurrence. So that means there's recurrent near the lymph nodes. So that's usually the side of the neck, and also the distant metastasis, so that's the tumor cells spread to the distant organs, to other parts of the body, and also death. And then the last one, disease-free survival, is more the combination of all these 4 outcome endpoints. And there are also other endpoints like progression-free survival or tumor-specific survival, but in this talk today I won't cover them. So then the idea within the DAME project is actually to develop like deep learning based models that focus on mostly the image features. So this is also how we started with this research question. So the idea, for instance, here is actually we have a scan from a 3D scan from a head and neck cancer patient, and where we just take a smaller 3D volume that contains the tumor regions, and then we use this volume from the CT scans, and then we just go through a 3D convolutional neural network, and here we use ResNet 18 as a backbone of this network, and then it is able to extract the underlying image features, and then we combine those image features together with the clinical parameters, and then these combined features can later also go to a multi-layer perception, so that's an easier neural network, and then the model is able to actually predict those outcomes at 2 years' time. So we are at this moment taking it as a binary classification problem, and this model is trained end-to-end in one go. So this is basically how the pipeline works. We focused for the head and neck. We focused on like 2 data sets. So the first is UMCG data set, where we collected like more than 400 head and neck patients. From the department. So we split them into the training cohort and also the validation cohort. So with the training cohort, we develop the model and then validate on the validation cohort. And also we performed the external validation on a public data set called the head neck PET-CT with around 300 patients. And so these patients are actually from 4 different hospitals and institutes. So, and then from the organizer of this data set, they have already split them into the training and then the validation. So we just adopted in the same way. So there are some of the results we got on the project. So we had the model trained, the pipeline I showed before, so trained on the UMCG training cohort, and then we validate on the UMCG validation cohort. So those are the ROC curves for the different endpoints I mentioned before. So if we just move our attention to the table on the right, so we could see the area under the curve was listed here. So for the regional recurrence, we actually had the best among the rest, and followed by the local recurrence, and then distant metastasis, and also the disease-free survival. And also from this curve, we could actually identify the best cutoff value for the to actually get the sensitivity, specificity, and the balanced accuracy. So you could see, like, for the sensitivity, the disease-free survival is actually in the leading position, and it all differs for different endpoints, so I will not elaborate here. And then so then based on those thresholds, we could actually also stratify the patient into different risk groups. So for instance, here we show the Kaplan-Meier curve. So these are the curves actually indicating the survival rate of the patient groups. For instance, the first plot is a survival rate that is related to the local recurrence, and then the second is related to the regional recurrence, and then the blue curve here in both plots actually indicate the low-risk groups because they have a higher survival rate, and then the orange lines are the high-risk groups, because they have also lower survival rate. And you could see actually the gap between these curves are quite big, and so it's for the local recurrence, but also for the regional recurrence. So we also did a test to see the distributions of these 2 different patient groups, and they turned out to be, for both endpoints, the difference is statistically significant. And there are also the same results, but for the other 2 endpoints. So for the distant metastasis, we could see before the 14 months, there's still a small gap, but then it turned out to be actually not statistically significant. And for the disease-free survival, we could see it's also, the 2 groups are really significant, the separation between the groups. So these are basically the results, and we also compared those model with the clinical only based models and also the image based models. So here are the clinical models. Basically, it took those clinical parameters, including like gender, age, and tumor stage, and lymph node stage, and the modality, so that basically if this patient received only radiotherapy or radiotherapy plus the chemotherapy, and also we used the marker called the HPV status and combined with tumor location, and also the WHO status. So we used those parameters to develop a model that is purely based on clinical parameters, and the same actually for the image features. So we used basically the upper part of the whole pipeline to build a model that is purely based on the image features, and then those are the results that shows the area under the curve of all these three different models. So you could see actually the combined model is giving better results on the EUC for better than the image and the clinical based models on all these endpoints. And it's also interesting to see that the image models is actually performing slightly better than the clinical only models. And then we also perform the external validation, so where we just validate the model on this head neck PET CT dataset. So this dataset has actually a little bit different on the endpoints. So instead of having the local and the regional recurrence separately, they combined these two endpoints. And then here is a result from a paper that used this dataset. And what we did was we first just validate the model trained on the UMCG training cohort, and then directly validate on the validation cohort of this dataset. And you could see actually the model was not performing so great. Only the local regional recurrence, these combined endpoints, the result is something similar. And then what we did was the similar as the published work. So then we trained the model again from scratch using the training cohort of this dataset, and then we validate on this dataset. So then from this we could see actually for the local regional recurrence and the overall survival, we are actually having better results than this work. But for the distant metastasis, there's still room to improve. And then we also actually applied similar ideas for a different patient cohort. So this time we focused mostly on the lung cancer, and where we try to predict the overall survival for these early stage non-small cell lung cancer. And these kind of patients, they usually receive this stereotactic or ablative radiotherapy, and it's a very complicated procedure, and the clinical outcomes vary significantly. Basically we had a similar idea. So there we have also 4D pre-treatment CT scans, and from this scan we could extract also a 3D volume that contains the lung tumor, and then basically same pipeline that goes through these ResNet-based 3D convolutional neural networks, and then we try to actually predict the overall survival from this. We also actually worked on like two data sets. The first one is on the UMCG data set, so we have the training and the test set, and then we also validate on the master data set. So here are the results. So if we look at the area under the curve, the hybrid model is actually giving the better results on both the UMCG test set and also the master test set than the deep learning image model. So the first is actually the only image-based models, and the second is the clinical parameter-based model. So so this combined model is actually performing better than the rest if we look at the area under the curve. And then we also did the similar to actually get the Kaplan-Meier curve for the overall survival for these two cohorts. So you could see for the UMCG cohort, also the difference within these low and high risk groups is quite significant. It's also statistically significant, but also the gap is quite large. And for the master cohort, it was a bit less, this separation of the two groups. So then conclusion. So what we did was actually, we combined these image and the clinical features, and those models are demonstrated to be more effective for the prognostic outcome prediction. And also we also looked into the Kaplan-Meier curve, so we could see it has the potential to also stratify patients into different risk groups. And of course, we are still working on the project, so there are still further development of the models is also necessary to improve also the performance. So yes, at the end, I would like to also acknowledge the people who are involved in this work, and they are, thank all of them. Thank you. These 30 seconds, no? There might be questions.
Yeah, thank you, Jiapan. I also have a microphone now, so I can walk to the screen and see if there are any questions. If you can put questions in the chat that you have for Jiapan, then I can ask them. One of the things that, of course, is apparent from both studies, basically, that when you apply it to another data set, then all of a sudden your performance becomes different. Mm-hmm. What kind of reasons are behind that?
I think there will be multiple reasons. I would say the most of the reason is, of course, the patient cohorts are different. So then the external validation, for instance, we use, they are having also different, for instance, different for the head and neck, they have also different tumor locations and also different stages. And also for the lung cancer data set, we could also see there were different sizes in the tumor. So I think this all probably brings those, we could see this drop of the performance. But this is in general also happening, with such models. So when you do external validation, you always expect something lower. So I was actually not surprised when I saw it.
Okay, you would expect it, but it might also be, it's an interesting concept, of course, that we have to do the additional training maybe, which is still
also additional validation.
Additional validation, and the training, of course, is still not allowed in the clinical practice. So that's going to be a big challenge for companies that want to run such products, because doing a additional training at a local site to adapt the model, then it's not anymore the model that was launched. So it changes, and it's going to be difficult to get accreditation for it again. I do see that you get applause in the chat, but I don't see any questions coming.
Okay. I hope it was clear.
Maybe one other thing, if you can go back to the resulting slides of the comparison, this one. No.
Oh yeah.
Yeah. So how should we deal with this? Because on the one side, when you want to look at specificity, you use the deep image model. If you want to look at sensitivity, you have to use the clinical model. If you look at the AUC, then you have to use the hybrid model. So That's a bit ambiguous.
Yeah, I understand the point. Actually, from my side, I look mostly on the AOC. That is, of course, not perfect, right? But I will leave the sensitivity and specificity for more the radiation oncologists for them to decide which would be the model that they would pick, because they are the ones knows really well which are the models that would really be like more useful for the patient selection. So yeah,
So
to put myself to be on the more safe side.
Yeah, so you would say it's about how you are going to apply the model. It's going to determine which model you would use. So if you want to have a higher specificity, then you should select maybe another one than when you want to have a high sensitivity. So it depends a bit on the application area in the clinical domain.
Yeah.
I do see that we are almost there for the next presentation. Get rid of this. There are no questions in the chat, so thank you again, Jiapan, for this nice overview of the work done in the DAME project on the side of the radiotherapy department. In about 5 minutes, we will be shifting again to the other room, where we will have the next presentation coming in, which is a presentation by one of the other partners within the project. So then Alexander Arendt will be giving a presentation, and he will be presenting on the usability aspects of AI. So all go to the side room, the room 2, I think it is. Room 1 it is, I see. And then we'll continue the program there. So see you there in a minute.